Hospital and continue with the stroke specialty. She will present about the novel oral anticoagulants, NOACs, for the treatment of cerebral venous thrombosis, an evaluation study in patient at Neurology Center, Bachmai Hospital. Over to you, Dr. Lin.
My name is Linh, and currently I'm working in Bachmai Hospital in a Neurology Center. And today I'm really honored to be here to introduce my presentation. My presentation about the novel oral anticoagulation for the treatment of cerebral venous thrombosis. And first we are going to see anatomy of the venous system. The venous system is divided into sinus venous and cerebral vein thrombosis. And the most commonly side we see the sinus venous thrombosis is the transversal sinus. It's about 20 to 60%. And the second we get is the superior sagittal sinus. It's about 25 to 45%. And cerebral venous thrombosis is a relatively rare type of stroke. The incidence in the world, estimated 2 to 15 per 1 million population, is seen in old age and more common in young population. The average age is about 37 years old, and the female to male ratio is 3 to 1, and the age of woman is younger than that in men. At Bachmai Hospital in 2020 and 2024, we get 120 patients per year. It's based in old age, and the average age of the disease is 42.4. Okay, and in Bachmai Hospital, if the patient have the clinical suspicion of CVT, the patient went through the MRI, and after confirm the diagnosis, the patient will initiate anticoagulation like IV heparin or subcutaneous low molecule weight heparin. And then if the patient have neurological improvement, we move to anticoagulation for the patient. And if the patient have the neurological deteriorated, we consider for patient for surgery. And we get some challenge in diagnosis. Is the CVT has clinical magnificency was variable and non-specific, and onset may be acute, subacute, or chronic, and symptoms are atypical. And the severity depends on the location of the venous thrombus obstruction. Headache is the most common symptom, and limit early diagnosis if the doctor is not a neurologist. So the natural cause of the disease consists of three stages. The first is acute, about several days. The second is immediate, several weeks to months. And the long term, about several months. In this stage, the patient has the lower risk of recurrence. And treatment accordingly to each stage of the disease. First, when the patient has started acute stage from 1 to 50 days, the patient recommend for heparin, low molecule heparin, or endovascular or surgery. When the patient have the maintained stage, the patient is about the 15 to 3 months, and we recommend patient for VKA, low molecule weight heparin or NOACs. And when patient trying to prolong maintenance, the patient will recommend for VKA, low molecule weight heparin or NOACs. Okay, and in 2021, in patient with provoked CVT, the patient will use anticoagulation for 3 to 6 months, and in the patient with unprovoked CVT, the patient will continue anticoagulation for 6 to 12 months. And we get some problem when using VKA, like narrow treatment range. We have to keep the INR index from 2 to 3 is really narrow, and VKA have leading cause of hospitalization due to adverse event of medication. So the question is, can NOACs replace VKA in cerebral venous thrombosis treatment? From 2010 to 2023, has many studies comparing the safety and effectiveness of NOACs in VKA in the treatment of CVT. First, we see the first study in 2014, comparing rivaroxaban and dabigatran to warfarin, and the next one in 2015, 2016, 2019, and the recently research is about accentivity and secret rivaroxaban is focused on research study in NOACs. Okay, we go into action CVT in 2020-21. It designed observational study in 1,025 patients. It's direct oral anticoagulation vaso warfarin in the treatment of cerebral venous thrombosis. And the result, the risk of recurrent venous thrombosis is similar between two groups. The death is similar in two groups. The risk of recanalization is similar in two groups. And especially the risk of major hemorrhage is lower in the group of NOACs. And have the meta-analysis of this study, so we see that in complete recanalization rate is no significant difference between the rates of complete recanalization of the venous sinus between the two groups using NOAC and using VKA in the treatment of CVT. And no significance between the VTE recurrent rate and mortality between the two groups. And the rate of major bleeding was relatively low in both groups, and there was no significance between two groups. Okay, so we conclude that NOACs are safe and effectively as VKA in the treatment of cerebral venous thrombosis. So when we compare NOAC with VKA, NOAC have some advantages like quick onset, like lower cerebral hemorrhage and can fix dose, few drug-food interaction, and no need to monitoring INR. And there's some disadvantages like high price, and some NOACs do not have a specific antidote. And when we see the VKA have more advantage, like can be used in patients with liver and kidney failure heavy, and there is specific antidote available. And especially VKA is really low price. And besides, VKA have many disadvantages like slow onset action and need to closely monitoring, and many drug and drug-food interaction and narrow treatment range. Okay, and in the guideline of American Heart Association in 2024, the NOAC have go to the guideline for the treatment of CVT in 2024. Okay, NOAC is divided into two types. The first is direct thrombosis inhibitor, is dabigatran. And the second is inhibitor of factor XA, is rivaroxaban, apixaban, and endoxaban. This is subtypes of NOAC. And the mechanism of action of NOAC. And in Neurology Central Bachmai Hospital, we do the research. First, when the patient go with the hospital and we confirm the diagnosis of CVT, the patient will use low molecule value of heparin for 5 to 15 days. And after that, the patient would move to rivaroxaban 20 milligram per day. And then after 3 months, the patient will go to us to do the MRI again, and we will assessment the patient. And the assessment criteria, we assessment patient between the effectiveness and safeness. Effectiveness, we elevate the patient, decrease venous sinus recanalization, the venous thromboembolism recurrent, and the decrease of disability. And the safety, we evaluate about major bleeding event, any bleeding and side effect. And our research that rates of venous sinus recanalization about 94.7%, and the rate of bleeding event is about 2.63%. And research published in the International Journal June in 2023. This is our public in Europe Review of Medication and Pharmacology Science in 2023. And recanalization of venous sinus after 12 weeks, its rivaroxaban is 94.7%. And we just have the one patient have bleeding under the skin, and one patient have the major nausea is major nausea. And in conclusion, venous sinus thrombosis is the rates from a stroke and account for 1.5 to 1% of stroke. And the diagnosis challenge from clinical symptoms are diverse and non-specific. And the maintain treatment phase depend on the stage, and prove that NOAC are safe and effectively at VKA in treatment of cerebral venous thrombosis. And compared with VKA, NOAC has many advantages and open new alternative treatment direction in the future. And we are keep collecting the patient in the future, and we hope in the future I can more opportunity more to present more result with everyone. And thank you everyone for listening.
Thank you, Dr. Lin, for your smooth presentation. So we are moving at the end of this day. But before I introduce the last speaker, I would like to inform an interesting and last-minute announcement, and it's very interesting, that Vietnam Association of Neurology decided to give the present to the best oral presentation for this session. So there will be 2 third prize, 1 second prize, and 1 first prize. So please join with us at the end. Who knows, you will be the prize award.